Good morning, guys. This next lecture is about cholangiography, the biliary system, the liver, and ERCP, and I'll explain, well, I'll just tell you right now, endoscopic retrograde cholangiopancreagram, and we will go over what that term means later, but we're going to talk about the biliary system in this lecture. It is the last portion of the chapter, I would say about the last third of the GI chapter in your Merrill's Volume 2. So I already did a previous lecture on upper GI, small bowel follow-throughs, esophagograms, and barium enemas. That was the GI fluoroscopy chapter, and then I've also done a video on the barium enema bag and preparation of the barium enema bag, and to the best of my ability, walked you through the steps to placing an enema tip. So this lecture kind of wraps up the study of the GI system, and the biliary system is separate from, but it's also an accessory to the GI tract. The excretion of bile by the liver and the gallbladder, if the patient still has their gallbladder, the production of bile by the liver, and the dumping of that bile via the biliary system into the small bowel is crucial in the digestion of fats and oils. So all of your fatty foods, anything that's oil based, any of those things, in order to extract the nutritive content of that material, bile is necessary to emulsify and break down those fats. All right, so we're going to talk about the anatomy of the hepatobiliary system, explain the preparations for the procedures. Most of them involve injection of iodine contrast via some method. The route of administration varies from procedure to procedure, but you don't use barium. You use iodine contrast, and you try to inject the bolus and get the bolus into the biliary system, the biliary duct system, excuse me. Image critique, images in various positions. There are going to be some key positions that I'm going to talk about for the gallbladder. The best positions for the gallbladder are just the straight AP, and then the RPO is another good position for the gallbladder and the biliary system, and I'll talk about why you would use those. Type, dosage, and route of administration for contrast agents. Route of administration is what varies the most. The type and the dose is pretty standard. It's usually somewhere on the order of 10 to 20 cc's of iodine, non-ionic iodinated contrast. Explain the purpose for using contrast media and possible contraindications for use. I can't think of any contraindications for, unless they were known to be obstructed, and then you're just going to make them miserable by adding pressure to the biliary system. Or if they had, well, even in the case of a peritoneal leak, the iodine contrast is reabsorbed in the peritoneal fluid and drained through the lymphatic system. So it shouldn't set up, it should be reabsorbed readily by the body if it gets to a unintended place, and it should be taken up by the lymphatic system without much in the way of infection or septic shock or any of those type of risks. So, all right, moving on. The liver is the largest gland in the body. That means it produces secretions. Among those secretions are bile. That's the most common secretion. And it secretes that bile through the right and left hepatic ducts that combine to form the common hepatic duct. And then that joins with the cystic duct to produce the common bile duct. Now, the cystic duct connects to the gallbladder, And the gallbladder is a cyst or a bladder, if you will, that lies, um, so it's a membrane fluid filled sac that lies underneath the liver. The picture they have here and the subsequent picture on the upcoming slide, they've turned the bottom of the liver up a little bit, like almost like you're prying it upwards, and then the gallbladder is tucked underneath the liver typically. It sits in close proximity to the duodenum, um, but most anteriorly is the right lobe of the liver, and then the gallbladder sits um, usually right around the mid-coronal plane underneath the right lobe of the liver. If the patient still has a gallbladder, sometimes they can have that removed. It's a organ that has a limited shelf life, somewhere around 40 to somewhere in between your 40s and your 60s. The gallbladder starts to um, suffer from disuse, especially if you've abused it over your lifetime. It starts to get too big, and then as diets change to accommodate high blood pressure and other health-saving changes, um, the gallbladder is used, the bile in the gallbladder is used less and less because you typically eat less and less fatty foods into middle age and um, old age because your cardiovascular system can't take it anymore. So the gallbladder by that point is hypertrophic for the new changes to your diet, and you get sludge and stones building up in the bile that used to be utilized. The large volumes of bile used to be utilized, but now not so much. So that's why stones and sludge manifests in middle age. Okay. To our next slide. The liver is supplied with blood from two. It's got its own circulatory system subroutine. So it gets conventional blood supply, oxygenated blood, from the abdominal aortic via the hepatic artery. But it gets its nutritive blood from the portal vein, and the portal vein connects to the mesentery, which and embedded within the mesentery, the portal vein divides into a capillary network that surrounds the small and large bowel and extracts the nutrients um, into the mesentery capillary network and the water and all the things that you glean from your GI tract travels from the GI tract through the mesentery and collects in the portal vein and then goes straight to the liver. So you don't dump um, nutrition and medicine and anything else you take in by mouth doesn't go directly systemically to the circulatory system. It goes to the liver for additional metabolic and chemical breakdown. In the case of medicines, turning it from um, the prescribed form into the active or the physiological form before it drops it back into the bloodstream. So the liver is very important in um, interrupting toxic things from circulating in your system, and but also processing some of your nutrition and turning it into a usable, physiologically useful um, portion for your somatic cells, for the cells of your body. So those are some of the functions of the liver. The liver also uptakes from the bloodstream, uptakes excess cholesterol and turns it into bile. So from the imaging standpoint, this production of bile is what we're keyed on physiologically because the biliary system is made to collect this bile from the liver, store it temporarily in the gallbladder, and then excrete it into the duodenum as necessary to support the digestion and absorption of fatty meals. Anything that has a fat content or an oil content to it is partially digested by production of bile. All right, so our biliary system consists of the bile ducts, the network of bile ducts, and the gallbladder. So, starting with the liver dumps its bile into two primary collective ducts, the right and left hepatic duct. The right hepatic duct goes to the right lobe of the liver, the left hepatic duct to the left lobe of the liver. And there's also a caudate lobe, and then there was one more lobe. The caudate lobe is like the tail lobe. It's the most posterior lobe, and that's a minor lobe. And then there's also a anterior lobe, but I forget what it's called. It's on the upcoming diagram. Right and left hepatic ducts join to form the common hepatic duct, and then the common hepatic duct unites with the cystic duct to form the common bile duct. Okay? And all of these ducts are shrouded by smooth muscle to aid in the excretion of bile from either the liver or the gallbladder. Okay, so here's the diagram in your book with the liver turned up. This would be if you were to see a laparoscopic um, cholecystectomy where they were cutting the gallbladder out um, via laparoscope. This would be the view that you would see on the camera because they use a trocar to kind of pry the liver up so it's standing up vertically, and this is actually the undersides of the liver you can see. Yeah, so that's it, the quadrate lobe right under the falciform ligament. So the falciform ligament, um, in the fetal circulatory system, the falciform ligament is actually an additional blood vessel for fetal circulation. But after um, birth, after the fetus is born, the falciform ligament, that circulatory system alters slightly, and the falciform ligament is no longer a patent vessel and immediately closes off and just becomes connective tissue that holds the right and left liver together. So it is a leftover piece of anatomy from um, everyone, and everyone has a falciform ligament that holds together the right and left lobe of the liver, left over from fetal circulation. Okay, the quadrate lobe is the anterior minor lobe, and it's basically the portion of the right lobe that finds itself on the medial side of the gallbladder. Um, is the best distinction I can, and then the portion of the right lobe that finds itself posterior to the falciform ligament is the caudate lobe. So those two minor lobes are basically smaller parts of the right lobe, and then the left lobe is more to the midline. Okay, and then in the green you see the um, biliary tract or the biliary duct network. The right, starting at the top, the right and left hepatic duct, and they merge to form the common hepatic duct. And then you have a gallbladder, um, and then the gallbladder is connected to the cystic duct. The cystic duct and the common bile duct merge to form the, the cystic duct and the common hepatic duct merge to form the common bile duct. And then the common bile duct, just before it reaches the duodenum, merges with the pancreatic duct. Okay? And then the hepatopancreatic ampulla. Good gravy, that was hard for me to get out. That has several terms. Now the ampulla is a wart-like, or the papilla of the ampulla is a wart-like projection into the small bowel, and we'll see that on an upcoming slide. Um, it is the very tip of the common bile duct, the union of the common bile duct and the pancreatic duct. Um, it's also called the ampulla of Vader, and we will get to that in upcoming slides as well. Okay. So the common bile duct joins the pancreatic duct. They empty into the duodenum via the ampulla of Vader, or the hepatopancreatic ampulla, and that is controlled by the sphincter of Oddi. Okay, so Vader is controlled by Oddi. You thought it was the emperor all this time, but no, it is um, the stupid. It is John's stupid dog that controls and rules over the Sith Lord. Okay, at least according to the biliary system. So, remember the definition of the word sphincter is muscular band. Ampulla is a small vessel, essentially. So, um, nitpicking and distinguishing the hepatopancreatic ampulla doesn't control the release of bile into the small bowel. That would be the sphincter of Oddi, and whether or not it's tightened around the hepatopancreatic ampulla or if it's relaxed. Right, and here is the picture of the papilla that we can see, and the ampulla of Vater forms the papilla, and it's a wart-like projection on the wall of the small bowel. So this is actually an endoscope picture of, and you see this little orange circle here on this picture by Dr. Murrah on February 5th, 2004. This bottom picture here. So we have this little wart-like structure um, on the side of the small bowel, and it's got a little orange tip to it. Well, that orange tip is the ampulla, okay, and the entire wart is called the papilla, and embedded in the wart, right under the warty flesh, is a ring of muscle tissue that squeezes on the ampulla and either closes it off or relaxes and allows bile to flow out of the ampulla. Okay? So that is the function of the ampulla and the sphincter in combination to deliver bile, and usually that is uh, the sphincter of Oddi is tightened unless there is the presence of fat in the stomach. There are certain receptor cells in the stomach that can detect the presence of oils and fats, and when those receptor cells are triggered by that presence, then the vagus nerve is stimulated and the sphincter of Oddi relaxes so that bile can be added to the small bowel to help aid in the digestion and absorption of those fats. All right. The gallbladder is a thin-walled musculomembranous sac. It is surrounded by smooth muscle, but there is an inner membrane, and it's a sac or a bladder um, found on the visceral surface of the right lobe of the liver. It's found on the underside of the liver, and the visceral surface, it is tethered to the visceral membrane or the visceral peritoneum of the underside of the right liver. Okay. The position varies with habitus. You can have one that's mostly vertical. You can have one that's more horizontal, depending upon how big a person you are. The gallbladder allows us to consume bacon double cheeseburgers and cheesecake, so it's extremely important. Um, you can live without your gallbladder, but your ability to eat bacon double cheeseburgers and cheesecake is extremely limited from that point on. So um, enjoy those while you can. The function of the gallbladder is to store and concentrate bile. It does not produce the bile. It is just a storehouse for it. Now, we don't always find ourselves eating bacon double cheeseburgers, though that happens intermittently. Same thing with cheesecake. We don't always eat cheesecake. So we need some place to store bile and concentrate it such that when we do eat something very fatty, we have available bile to help digest it. Otherwise, we can run into an indigestion issue. Um, Evacuates bile when activated by hormone cholecystokinin that is released um, by stimulation of the vagus nerve. Okay? So the endocrine system works in combination with the nervous system to get the gallbladder to squeeze down. Um, if you want to feel your gallbladder squeeze, I recommend that you fast for an extended period, 16 hours ought to do, and then try to eat an entire Hershey bar on an empty stomach, and you will feel your gallbladder squeeze. Okay? The neck of the gallbladder consistent with the cystic duct. That is, it is essentially the gallbladder just tapers into the cystic duct. All right, so the anatomy of your gallbladder, it shifts more toward the midline and becomes more vertical with a thinner habitus. So the asthenic person, the gallbladder is nearly in the pelvis versus a hypersthenic person, it is almost right up underneath the diaphragm. Okay, and it varies according to habitus. Not a lot of difference between the sthenic and the hyposthenic. For most folks, you will find the gallbladder in the right upper quadrant of the abdomen. That's important to consider when you're considering radiography of the biliary system. All right, so in order to visualize the gallbladder and the biliary system, there's three primary procedures. Now, they might dream up additional procedures and you might encounter additional procedures, but for conventional contrast assisted X ray technology, percutaneous transhepatic cholangiography, that is likely to happen in CT more than it is fluoroscopy, but it's within the realm of possibility. You can get an old school radiologist that wants to do it in the fluoral room and then transfer them to CT post injection. Um, Postoperative T-tube cholangiography requires that they've had surgery with a T-shaped drainage tube attached to their biliary system, cannulated through the cystic duct. So usually the general surgeon, if it's a T-tube, if it's been a gallbladder, a cholecystectomy, um, back in the day, the best thing they could do was to prevent stones and prevent the um, aggravation of stones post procedure and allow the person to heal. Was they put in a T-shaped drainage tube directly to the biliary system um, that could drain off excessive bile and relieve pressure while the patient attempted to pass their stones post operatively. Um, it's a rare occurrence with a laparoscopic procedure that we see much T-tube cholangiography anymore, but it does still exist, so the technologist should be familiar with the procedure. Typically, the T-tube has to be clamped for a certain duration pre-cholangiogram, and then you inject the contrast through the T-tube drain. Okay? And then you do another clamping so that the contrast does not drain back out of the T-tube during fluoroscopy. And then the last one, endoscopic retrograde cholangiopancreography. That involves the patient being sedated and an endoscope being placed through the esophagus, through the stomach, through the small bowel, and then cannulate the biliary duct with a catheter at the tip of the endoscope. And that's usually a fluoro-assisted procedure. Water-soluble iodine contrast-based media is used. Low persistence, well, what does that mean? Well, low persistence means that we want an iodine, we want a contrast that is going to, once we place it in the biliary ducts, we kind of want it to stay in the biliary ducts. So um, now, if the patient sphincter of Oddi is relaxed and they're draining into the small bowel, we can't really help that. But sometimes clamps are applied in the cases of intraoperative and postoperative cholangiography, such that the iodine does not drain back out and does not leave the biliary system until pictures can be made. Okay, the biliary system does like to drain fairly rapidly, so you might find yourself, especially if you don't get pictures in short order of the biliary system, might find yourself doing multiple injections. Typically, the iodine can drain out of the biliary system in as small as 20 minutes. Risks are still anaphylaxis and infection. Should be utilizing sterile technique when injecting contrast into the biliary system through any of the procedures, and the patient should be screened with history and physical pre-procedure to ensure that they are not allergic to iodine contrast, because um, the contrast will end up in their small bowel and they will absorb it into the circulatory system post-procedure. So percutaneous transhepatic cholangiography, a lot of times you see this um, in CT or ultrasound assist, but sometimes you see it um, in conventional fluoroscopy as well. It's a PTC, and percutaneous means from outside the body or from outside the skin surface. Transhepatic means across the liver. Cholangiography means recording of the angiographic vessels, um, the vessels pertaining to the biliary system. So stick a needle through the patient's skin, across the liver, and access the biliary system, and then inject contrast and take pictures. It's pretty straightforward. Okay, um, your radiologist should have skill in placing that needle and advancing that needle um, into the correct location via either fluoral guidance, sonographic guidance, or CT guidance. There are some risks associated with that procedure. We already mentioned that the portal vein and the hepatic artery join the liver and supply blood to the liver, and they're in close proximity to the biliary system. So without um, some kind of imaging guidance, um, the procedure becomes a high risk procedure, because you could do a internal stick on the hepatic artery, and that would be bad for the patient. Uh, that would lead to a peritoneal hematoma for sure. Sometimes in a PTC, you are placing a drainage catheter. So you could place a needle, then a guide wire, and then a dilator, and then a catheter through the dilator or introducer sheath um, in order to promote drainage if the patient has chronic history of bile stones. It might be possible that they're being fitted with a temporary catheter via a PTC in anticipation of an upcoming cholecystectomy surgery. Perhaps if they're made to wait for the surgery, it might be that the physician says that a drainage catheter should be applied in order to relieve some of the pressure from the obstructions due to the stones, and a drainage catheter would be able to relieve some of that obstructive pressure and relieve the symptoms of jaundice. Okay? So here's our PTC image. You can see the arrow indicates the needle gaining access to, it looks like the right hepatic duct. And then you can see the left hepatic duct is lit up. Um, the cystic duct is lit up. And a very tortuous common bile duct is lit up. And at the very bottom of the image, contrast is passing into the duodenum of the small bowel. So lots of staples present. Looks like the patient has had um, some surgery as well. It might be that they've had their gallbladder removed because I don't see a gallbladder filling um, specifically. It looks like there might be a cystic duct here at the middle of the image, um, but it looks like it comes to a end in close proximity to the staple. So it's possible that they've had with the abundance of staples here, they could have had a Roux-en-Y or a gastric resectioning or um, perhaps some kind of small bowel um, or GI tract surgery where they removed a loop of bowel previously with all these staples. I don't specifically see a gallbladder filling up. They may or may not still have a gallbladder. It might be just early in the injection and the gallbladder hasn't filled just yet, and it's in this empty space in the lower right hand corner of the image. Um, this is a straight AP. You can tell by the pedicles and the spinous processes relative to the thoracolumbar region where we happen to be doing the radiograph. So notice that the common bile duct overlies a portion of the spine and parts of the hepatic ducts overlie a portion of the spine. So you get superimposition by the spinous structures on some of the biliary structures. Depending upon how bright your contrast is, it might make it difficult for you to see obstruction or stenosis or pathology of the biliary system with superimposition of the spinous structures. Okay? A PTC uses what they call a chiba or a skinny needle, and it's exactly as it's described. It has a very, very tight lumen such that it's not going to promote excessive damage to the hepatic tissue. Hepatic tissue is very vascular, and if it's torn or um, cut by the needle, um, could lead to internal hemorrhaging. Okay. For a T-tube cholangiogram, again, the surgeon is going to be placing, this is a post-operative typically, and it's the surgeon that places the T-shaped drain valve after removing the gallbladder. The stem of that drain tube cannulates the remains of the cystic duct, and then the T goes up into the common hepatic duct, and then also down into the common bile duct. And that T tube promotes drainage of the biliary system in the event the patient still has stones to pass. Okay, it wasn't 16 hours before. We want to clamp the tube off 24 hours before to remove air bubbles from the tube or the duct um, pre-procedure. Because air bubbles, which could be with the alternate drainage of the biliary system, air bubbles could be introduced to the biliary canal via the small bowel. Um, because there is an addition, this T-tube creates an additional exit route um, to the biliary system. The pressure between the biliary system and the small bowel might reverse, and you might actually draw air in via the sphincter of Oddi. Now, air will create a filling defect, and it will be indistinguishable from a gallstone during the procedure. So to prevent an air-filled duct You want to clamp off the T-tube um, for fluoroscopy the next day, evaluation fluoroscopy and injection the next day. Okay. So why are we performing a T-tube cholangiogram? Well, first of all, we want to demonstrate that the ducts are patent. That is, that there are no other stenoses or stones present. And if there are residual stones, where they might be located and whether they might be extracted by an ERCP. Want to see if the sphincter of Oddi is relaxed or contracted and stenosed, and whether that needs a sphincterectomy, which you can perform during an ERCP. You can actually cut into uh, part of the sphincter and render it permanently relaxed until the scar tissue forms. Okay. And then caliber and patency of the ducts. Are the ducts dilated because of the presence of stones, or have they reduced toward their uh, typical or normal size post-operatively? Okay. The ducts, when the ducts dilate, the hepatic ducts are typically about the diameter of a soda straw when they're unobstructed, but they can get a wide as round as your index finger uh, with the presence of stones or stenosis. Again, we don't want air bubbles because that's a filling defect, and the radiologist will not be able to distinguish between a stone that is a filling defect in the contrast and an air bubble. Okay. Preceding meal is withheld. We want a nice reservoir of bile. Cleansing enema 1 hour before the procedure if needed. Typically that is to clear any stool contents out of the large colon because the hepatic flexure sometimes overlaps and the transverse colon overlaps with the biliary system, and if there's a massive stool there, it might obscure adequate diagnosis of the biliary system because of the superimposition. So ideally, um, the large colon is cleaned out prior to your cholangiogram. Preliminary KUB is obtained for a comparison view pre-injection of contrast. They might want a conventional KUB and a non-contrast RPO with the gallbladder rolled out to the right and the spine rolled to the left. That's what an RPO position does, is it separates the gallbladder and the biliary system from the midline and puts it squarely in the right quadrant of the right upper quadrant of the abdomen, well away from the spinous structures. So check with your radiologist to see if they want more than just a KUB for the scalp film. They might want that non-contrast RPO for comparison as well. Okay. And this is the RPO. See now how the common bile duct has shifted off of the spine and doesn't superimpose with the spine. Okay, and it looks like there are 1, 2, 3, 4, 5, 6 points of interest here on our T-tube cholangiogram. We ought to be able to, on a quiz, identify these points of interest. So I'm going to make it easy for you. The first one is the right hepatic duct. Um, that's the first indicator on the top. The second line, the black and white line down, is the um, common hepatic duct. The third line down is the T-tube, which is cannulating the old or the remnants of the cystic duct. Um, the fourth line down is the common bile duct. The fifth line down is the pancreatic duct. And the sixth line down is the duodenum. Okay. So we position the patient in the RPO in order to roll the biliary tree away from the spine. Okay. The spine is a posterior structure, and the biliary tree, roughly in the mid-coronal plane, centered somewhere between the center of the right upper quadrant and um, the midline of the abdomen. If we roll the patient RPO, then the more anterior anatomy, which is the biliary tree, will roll toward the right, and the more posterior anatomy will roll to the left. Contrast is injected into the T-tube under fluoro, and remember, the T-tube is placed by the surgeon, not by. It should be, the patient should come with the T-tube drain, and that T-tube should have been clamped since the day before. Your radiologist will want to turn the patient in several, after they inject the contrast, will want to roll the patient in several different positions and make spot films. You may be called upon to do an AP and an RPO post fluoroscopy for a T-tube cholangiogram. All right. An ERCP, endoscopic retrograde cholangiopancreagram. Sometimes these are done in the fluoroscopy procedure table room. You know what I'm saying? Fluoroscopy room. Other times these are done remotely in the OR or similar room outside the department with a mobile fluoroscopic C-arm. So depending upon your facility is how you will encounter your ERCP. Now, the endoscopic retrograde, that's on the gastroenterologist. They have to pilot the endoscope through the patient's mouth, down their throat, down the esophagus, through the stomach, into the duodenum, and then they also have to cannulate via catheter and wire the hepatopancreatic ampulla and the sphincter of Oddi, and then inject the contrast through their endoscope. Okay, you are there to take an occasional fluoroscopic spot image to assist them with cannulation of the hepatic duct, or I'm sorry, the common bile duct, and then once they have cannulation, to record the retrograde injection. Now, what did retrograde mean back when we covered urography and cystography? Oh, yeah, that means the contrast is introduced uh, opposite from the normal physiological flows of the system. Well, does that make sense here? Yeah, because bile is supposed to come from the liver and flow down and exit into the small bowel. But that's not the way we're injecting contrast. We're injecting contrast from the small bowel back up into the biliary tree toward the liver. So that explains the use of the term retrograde. Okay. Useful method when ducts are not dilated and ampulla is not obstructed. Okay. Sometimes it is difficult cannulating um, in this fashion when um, the common bile duct is very tortuous or there is a stenosis or obstruction at the ampulla. Okay. Sometimes that can be overcome, sometimes it can't. Okay. The patient's throat sprayed with local anesthetic. Again, you're not going to be passing the endoscope. You're going to be running the fluoroscope to assist the gastroenterologist in the steering of the endoscope to get to the hepatic pancreatic ampulla and to cannulate and inject contrast. Okay. Once you inject contrast, you'll be called upon to take um, some AP projections. You might do some RPO projections, um, and it might turn into a therapeutic. If there are stones, then the gastroenterologist may choose to use the endoscope and various tools employed with the endoscope in order to extract the stones and get the stones out of the common bile duct. Right, so here's our ERCP image. You can see our endoscope here at the bottom of the image. It's coming in from the esophagus, going through the stomach, and then into the small bowel here at about on the right half of the screen here. And then there's a catheter coming out of the coming out of the end of the endoscope, and the catheter has entered the ampulla and is injecting contrast that's filling the common bile duct. You see the three staples there right under cystic stump. That means the patient's had their gallbladder removed. Um, this is slightly dilated, but not aggressively dilated. We can also see the pancreatic duct has not been dilated at all. So the patient may have had gallstones previously, but it looks like the dilation of the biliary system is starting to reduce. It's only moderately dilated with no dilation of the right and left hepatic duct. Those are actually normal size, as is the pancreatic duct. So only the common bile duct is mildly dilated. This is a negative ERCP. There's no stones present. There's no signs of active stenosis. Uh, so it doesn't look like any interventions are necessary. Interventions I've seen personally with performing ERCPs, I've seen stone extractions via sphincterotomy, ballooning um, the common bile duct, and or using the wire basket to grab and lasso stones and pull them out of the common bile duct. Sphincterotomy just cuts a hole in the side of the ampulla and allows for a wider opening into the small bowel. Um, with a balloon, what you do is you put a catheter with a balloon attached to it and advance it all the way up into the hepatic duct, and then inflate the balloon at the union of the hepatic ducts, and then just drag the inflated balloon down the common bile duct, kind of like a snowplow, and just pull all the contents of the bile duct out into the um, small bowel. Okay? So I've seen that during an ERCP, and I've also seen a stent placed to keep the ampulla opened and allow for free drainage and that was in extreme cases. In the case of cancer, sometimes you can get a pancreatic cancer that envelopes and closes and stenoses the common bile duct to the extent that it's extremely closed off, and you actually need to balloon stretch it open and then hold it open with a stent in order to get bile to pass. Okay. Registry focus, you are going to need to know what ERCP stands for. You're going to need to know how a procedure is performed. Um, so, and uh, what happens during that procedure. Okay. So, of these three choices, which are correct? Which happens during an ERCP? And if you said 1 and 2, you would be correct. We do not inject barium during an ERCP. Okay, you'll do that during an upper GI or a small bowel follow through, but you won't do it during an ERCP. All right, guys, that is the hepatobiliary system in a nutshell. We went over the anatomy, we went over the preparations for the procedures. We did look at a couple representative images as provided by the textbook as far as image critique, and I pointed out various structures and various anatomy of the biliary system, the type and the dosage of route of administration of contrast agents. Remember I said the route of administration varies according to each procedure type, but the type and the dosage are pretty similar. It's about 15 to 20 cc's of iodine contrast, non-ionic, for biliary systems. Okay, and why we're using contrast is so we can see the biliary system and rule out the presence of either gallstones or stenosis of the common bile duct, and keeping the whole point is patency of the common bile duct so the patient can pass bile in according with normal physiological process. All right, that's all I have. Hey, look, I kept it under an hour bonus. I will see you guys when I see you guys. Enjoy your break.